All right, so we are recording, and so just again for anybody that may not be here, or and I'll post this later today so that you can go back and review it should you want to. We have an exam on Wednesday. It will be computer based, so bring a laptop, bring a tablet or something where you can access the internet. All of your rhythm strips will be short answer, which means you got to type out the name of it. Now, remember, there are some rhythm strips that will have an underlying rhythm. If you want the full credit, you got to tell me that underlying rhythm. So, for example, like with PACs, if you just simply say PAC, you'll get half credit. With first degree block, if you just tell me first degree block, you'll get half credit. All right. There will be some bonus questions on here that I'm purposely making really, really challenging because they're bonus questions. But it comes from the content that we've studied all semester long, as well as from your study guide in here as well. If you miss those bonus questions, they're not going to hurt you. They can only help you. Okay. So as we're going through the review, this is going to be very similar to what you're going to see. And I've got some examples of the types of multiple choice critical thinking questions that are scenario based. These scenario based questions have a tendency to drive students crazy because as humans, we like to memorize things and just regurgitate them back. In this situation, what I'm going to do is I'm going to give you some pieces of information and I'm going to want you to make an informed decision based on what the options are going to be. On all of those scenario-based questions, they will all be multiple choice. So you'll only select one, okay? So as we're going through here, what is that rhythm? And you're welcome to take pictures, but I'm also going to share this PowerPoint with you as well. So there's nothing secret on this PowerPoint that I don't mind. Yes, Dylan. Why is this sinus arrest? Good job, by the way.
Because there's more than QR. Is it one QR?
More than one. More than one dropped QRS. So two or more make this a sinus arrest. Now, again, as we're talking and going through this, from a pathophysiological perspective, what is your big concern with this rhythm? What if, let's do this. What if those were now dropped? What's your patient going to experience? What are they going to do, Abe? Why? You're right. Now tell me why you're right. Why? Braden. Why?
Because they have
You're right. Yeah. So the law of supply and demand. Remember, in here we have a drop, multiple QRSs, probably two. Okay. Let's see, 1, 2, 3, 4, 5, 6, 7, 8. So we've got about a 10% drop, or almost a 20% drop, or a little bit more even, of QRS complexes. And so if you took a 20% cut in your paycheck, meager as it is, would that hurt? Every one of us, it would hurt. Okay. And so it's the same thing with sinus arrest. The big thing we're concerned about, Braden, good answer, is a reduction in cardiac output. Yes, it is most likely going to lead into shortness of breath. What other kind of symptoms might you see? Braden? Low blood pressure. What else? Pale, cool, and diaphoretic. What else? May not be alert and oriented. What else? What would be a really common one? Say it again now.
Like symptoms, like
potentially, yeah. So it could. But what about their chest? What might they complain about their chest?
pain.
They might be having some pain or discomfort. Okay, And so, again, when we're looking at this, don't look at this and immediately go, oh, I got to do something. You got to look at this and go, oh, I got to assess my patient. Okay, I got to assess my patient. Because if this only happens once, it's not going to be a big deal. Okay, but if this is happening 1, 2, 3, drop, 1, 2, 3, drop 2 beats, 1, 2, 3, drop 2 beats, your patient's probably going to have some complaints. First of all, everybody clear on why this is sinus arrest and not sinus block? Okay.
My question was,
go ahead.
So this mainly just shows the electrical activity. Is it possible for you to still feel a pulse within that?
I love you guys. Most of you. I'm joking. All of you. It is possible, but probably, if this is actually what's happening, probably not. Now, let me ask you a question. All right. And again, this is part of your assessment. You see this on the monitor. One of the first things you're probably going to want to do is to go hands-on with your patient. Okay. So again, for patients awake and alert, don't check a carotid pulse. That's just going to scare them. But come down here to the radio and check. Now let's think about this for a minute. So you're checking radial. You got beat, 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 beat. Okay, that lines up with that. But now, what if you were feeling the radial, Tacey, and you got beat, 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 and this is what you're seeing? What might be causing that differentiation? And not just Tacey, but anybody.
Would that be an issue with lead placement?
Malfunction of your equipment is most likely going to be the big thing. So again, this is why, ladies and gentlemen, I tell you, don't treat your monitor. Okay? Monitors will never call you. Monitors will never dial 911. Monitors will never pay your salary. The patient in front of you will. So again, this is just a tool that you're going to use. And so don't base your entire diagnosis off of one finding. All right? Anybody else, this is really, really good. We have a good discussion. You put me in a good mood. We might talk about some bonus points for taking the exam. I don't know, Discussion always makes me happy. Any other questions? All right. Here is your first critical thinking question. Okay. It's tied to objective number 2. Know the conduction system of the heart. You respond to a 65-year-old male complaining of dizziness and near syncope. What is near syncope? Yeah. Oh, man, I almost passed out. All right. His vital sign shows BP 110/70, heart rate of 42, respiratory rate of 18, and SpO2 of 97%. See anything concerning there? His heart rate is slow, but what do you see about the rest of his vital signs? 97 is pretty good. Anything above 94 is considered normal. Okay? See anything else that's kind of weird looking when you see a patient with a heart rate of 42? What about his blood pressure? Not really.
It's lower than most.
Yeah, well, again, remember, we'd have to look at our patient. It might be a little bit low because the dude is 65, and trust me, if he's 65 and he's a male, he's probably going to be on some kind of blood pressure medicine. So you're right, that could potentially be low. But that's not bad for somebody that's got a heart rate of 42. Okay? His respiratory rate, what do you see about that? Completely normal. Completely normal. So he's got maybe a little bit lowered blood pressure. We don't know for sure. But he's got normal respiratory rate and a normal SpO2. Let's go on. The EKG shows regular P waves occurring at a rate of 80 a minute with only some P waves followed by QRS complexes. When QRS complexes occur, they're narrow with a normal morphology. What does the word morphology mean?
The shape.
Yeah, they're shaped. They look Normal. What part of the cardiac conduction system is most likely affected in this patient? A lot of information here. Trust me, guys, you'll have plenty of time to look at these questions because I'm not going to give you a 100-question exam. Okay, first of all, I'm lazy because I'd have to grade it. Second of all, is a 100-question exam is not going to give you time to think through these questions. So it's asking what part of the cardiac conduction system is most likely affected in this patient. And everything in these questions is important. I do not put fluff. These are going to be very similar. If any of you are EMTs, you've already seen these kind of questions before. Okay. I'll let you in on a little hint. After class today, I'm headed up to the registry's office in Ohio. I'm part of the committee that builds these questions, so don't hate me for that. But the good thing is I can get you ready for your exam. Okay. I can't tell you the questions you're going to get because I don't have a clue. Wouldn't do it anyway. But this is the kind of questions you can expect on your registry exam. What part of the cardiac conduction system is most likely affected in this patient? SA node, AV node, bundle of His, or the right bundle branch? Read everything in that question and tell me what you think your answer should be.
It's like the waves are occurring normally, so you know it's not that same node. You know, the QRSs are not occurring normally, so something is stopping them from going through. That's normally the AV node. It's like getting something's happening there. It's not letting it go down to the other ones.
Okay. Faith was brave. She went first. I appreciate that. Anybody a different answer? Anybody just too scared to answer? Look at there. Here, you're teaching the rest of the class. That explanation was awesome. So basically when we're looking at this particular rhythm, it's slow. He's got P waves occurring at a rate of 80 a minute, but only some of the P waves are followed by QRS complexes. Now let me ask you a question. Can you identify the rhythm from that description?
You can narrow it to a block.
Good answer. You're exactly right. We can narrow it to a block. We're not sure which block because we don't have enough information. That again comes back to that 5-step process that you got to know. But we can narrow it down of when you got more P's than you got QRSs. Now it's a block. Very, very good. Where's your compadre, man?
He said he was going to be here today.
Okay.
Has some kind of stomach thing.
Oh, man. All right, here we go. Next rhythm.
Sinus arrhythmia.
So I got a sinus arrhythmia over here. Anybody anything different? So I went last week and upgraded my hearing aids. Obviously, I've told you I had, and they haven't been programmed yet. So please shout at me because I can't hear hardly anything today. Oh, whoa now. Whoa. You want full credit? Do you want full credit? Good. Very good. Yeah. This is normal sinus rhythm with PSA. Let's look and see why. Okay. So as we look and we're going through here, let me do it this way. That way everybody can see on both sides. So as we look and we're going through here, our underlying rhythm is regular. We've got P waves that look normal. We've got a normal looking PR interval. The QRS is normal. Everything is normal. And even with this one right here, it looks normal with the exception of there's two things that are abnormal about it. What is it? What's abnormal about this complex right here? What about the P wave? That's one of them. Why is it smaller? Why is it shorter?
It's not having enough time to build up.
Say it again. And it comes in too quicker. It's kind of like being more worser or more better. You're right. It does come in. And so is that it comes in more quicker. I'm going to use that from here on out. Why does it look different though? Say it again. Yeah. So you got the T wave that is depolarizing, and then you got that little bit of a P wave that's coming up on the side of it. Okay. That's one big change. What's the other change? It's in its name, ladies and gentlemen. It's premature. It is early. Now, let me ask you a question. What do we call this space right here?
Compensatory pause.
Compensatory pause. What is the purpose of a compensatory pause? You will not always see that, but when it is there, what's the purpose of the compensatory pause?
To compensate for the early contraction, so it gives it enough time to get back into that original rhythm.
Perfect. It allows the heart to go, wait a minute, something happened. Okay, gotta take a deep breath. Let's get back to a normal rhythm. Okay. Most of the time, your patients will not feel this unless they have a bunch of these. And then they will say, man, I got a bunch of skip beats. Now, simply because they're telling you they're having skip beats and they're feeling them does not always guarantee that it's going to be a PAC. It could be a PJC. It could be a PVC. We've not covered those yet. We will. Okay. But that's exactly what it's going to be. Good answer. Make sure you tell me the underlying rhythm. Okay. All right. Here we go. Next one. I'm sorry. Yes. As long as you abbreviate correctly. So, for example, if you put S bradycardia or NSR or S tachycardia, 100% okay. If you put A flutter or A fib, 100% okay. If you put AF, no bueno, because I don't know if that's atrial flutter or atrial fib. Okay. You should never, ever, ever put tachycardia. That's never a correct answer. So again, it's either going to be a sinus tachycardia or a junctional tachycardia or a ventricular tachycardia. So it's got to have that proper name. But yes, you can't abbreviate as long as the abbreviations are correct, and that's what we've covered in here. So what we've got up in here, if you write this down right like that right there, 100%. Now let me tell you the other thing. Okay, on this, because you guys are doing well, and I'm starting to feel generous. There's room for improvement. If you tell me that the 1, 2, 3, 4, fifth impulse is the PAC, I'll give you 50% of whatever that point value is in addition. That's why I put it in as a short answer. Okay. If you tell me it's the third, I don't take any points away from you. If you say it's normal sinus rhythm with PAC and it's the third impulse, I'm not going to take any points away, but you just don't get the bonus points. Do you have a question?
I was trying to figure out what, like fifth what? I guess.
Fifth complex. So again, starting over here, that's 1, 2. Okay, Bill, use technology. 1, 2, 3, 4. That is your fifth complex. If you say the fifth complex is the PAC, ding, 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 you get bonus points. All right? Everybody clear on that? And I'll explain it out in the directions of before we start, okay? Any other questions? This is very good. Yes? Just like I said, fifth complex is the PAC. Yeah. Or you may have multiple PACs in there, and if you identify, and I want you to identify all of them if there's multiple. So it's like the third and the fifth complexes are the PACs. Good. Anybody else? All right, here we go.
One.
Okay, so I got a second degree type 1. Dylan? I got a third degree. Anybody else? You say third degree? So the correct answer is indeed it is a third degree block or a complete heart block. Either one of those is the correct term. So let's look and see what this is, okay? So we start out here, and again, remember when we're talking about heart blocks, we're looking, in particular, we want to pay close attention to the PR interval. So remember, if the PR interval is regular, it can only be first degree heart block or second degree type 2. If the PR interval is irregular, if it changes, it can only be second degree type 1 or third degree. So let's see. Now we're looking at this PR interval, and you can look at it and see over here that it changes and then it changes back, but there's no real pattern to it. So that immediately tells us it's in the second column. It's either going to be a second degree type second degree type 1 or third degree. What happens to the PR interval in a second degree type 1?
It steadily elongates and then it drops.
Love being around smart people. Yes. Yes. Is that what we see happening here? No. There's no pattern. There's no rhyme or reason. Here's the other thing you can do. And I will allow you to have one sheet of plain white paper if you want to use it to measure on your screen. If we measure out from here, that's a perfectly identified P wave, and we measure out to here another perfectly identified P wave, and we walk them out, we can walk out our P waves. But here's the other thing I want to point to you. You see this right in here? That's not just your T wave, ladies and gentlemen. That is a P wave embedded in a T wave. Okay? And that's why it looks the weird it does. The other thing we also have to look at here is look at how wide this QRS is. Why is the QRS wide and bizarre looking? It's definitely having to go around the block. So it's taking its different path. So we have the atria that is firing up in here. That impulse is never getting down to the ventricle, which means the ventricle, because of what property? Automaticity, is now fires off at a slower rate, but it also fires off with almost always a wide and bizarre looking QRS because it's going different than the normal conduction pathway. Everybody see why that is? Anybody not? This is a time to ask. Nobody's going to make fun of you. I promise. Next critical thinking question, still at the conduction system of the heart. While monitoring a 72-year-old female recovering from an inferior MI, you notice that her heart rate has dropped to 38. She reports feeling lightheaded. The cardiac monitor shows regular QRS complexes with no visible P waves and wide, bizarre-looking QRS complexes. What is the most likely origin of this escape rhythm based on the conduction system? The atria, the bundle of His, the ventricular myocardium, or the Purkinje fiber network? I got quiet in here. What do you think, Abe? I think that's the atria. Now, make sure you know what the question is asking, okay? It's asking here, what is the most likely origin? No P waves, wide, bizarre QRS. We actually just talked about that. Braden?
If it was a wide, you look at this an abnormal QRS. Or
Yep.
the blockage. It's going around block.
And then it's like length of it is different.
Well, it does say it does say there's, okay, first of all, there's no P waves. So think about what's going on. If there's no P waves, what's not happening? There's nothing coming out of the atria. So if there's no P waves, we can immediately eliminate A because it's not coming out of the atria. So that leaves us with B, C, and D. If it's wide and bizarre and slow,
That'd be ventricular.
and where, okay, so it comes from the ventricular myocardium. And I need to go back and rework this one, okay? C or D could be the right answer. Okay, I've got it Purkinje. Now, where do we find the Purkinje network? Right at the very bottom. Okay, right at the very bottom. Now, it is possible, okay, it is possible. This is one of the reasons I like doing these. These are new questions that I've developed. It's possible it could be coming from the ventricular myocardium. So that would be a right answer as well. That's just the ventricles, the ventricles. The myo is muscle, cardium is in the heart. So it's the ventricular muscle. And remember, every cell in the heart can generate its own impulse. So if it's coming from the ventricular myocardium, it could be indeed be wide, bizarre, and slow. Okay? Everybody good with that one? Did I confuse anybody? All right. Abe.
I think that has to do with the rhythm, like their
Regular. It's regular. And remember, when we're talking about regularity, we're talking about R-to-R intervals. Okay? Now, don't mistake the word regular with normal. Let me show you something. Are those normal-looking QRS complexes? Why not? They're wide. Are those regular QRS complexes? Why? Say it again. It's a regular rhythm. So if we measure from, bless you, if we measure from here to here, the distance would be the same to this one, and to this one, and to this one. So that's the difference between the word regular and normal. Okay? Regular and normal. Good question, though. Anybody else? Name that tune. Say it loud. Cardio with first degree block. Excellent. You get full points. If you tell me that is a first degree block, you will get half the points. If you tell me that is a sinus bradycardia, you will get no points because you got to include the block in it. All right. So again, what is the key finding for a rhythm of any type that has a first degree block? That is, say it again, Dylan. Consistent. It's got to be consistent. Excellent. Ain't that rhythm? Let's see why it's normal sinus rhythm. Everything's normal about it. The rate, the rhythm. P waves look normal. PR interval is within normal width. QRS is narrow. Okay, what's the normal width of a QRS? 0.12 or less. Okay. What's that rhythm? Right. So Braden says wandering atrial pacemaker. Anybody else? Say it again. Secondary type 1. I got a secondary type 1. I got a secondary type 2. Anybody want to go with a third degree? Can I get a third degree, huh? All right. Now, I'm not going to give you this one on an exam because, again, this is an entry-level class. That's third degree block. Now, wait a minute, Bill. Hold on. You just said, what did I just say about third degree? There's no pattern there.
But you have the
QRS, as far as the width,
is normal.
looks pretty normal. Now let's think about this for a second. Why is that QRS? This may be a bonus question. Why is that QRS narrow and it's a third degree block? When I just got done telling you that in third degree block, usually your QRS is wide and bizarre looking. What's up with that? Maybe. What else? Tell me more.
But depending on where the block is, that would change the morphology. So if it's
Not the block. Not the block. It So most likely what is happening is the cell in the ventricle that is firing somewhere near the bundle of His. That's why your QRS is narrow. Now again, I'm not going to give one like this, but I like this slide because you could potentially see this maybe as a bonus question. Okay. Everybody understand why it's third degree block and most likely why it is a narrow complex. All right. All right. You're treating a 54-year-old marathon runner with a heart rate of 48 who is asymptomatic. His EKG shows normal P waves followed by normal QRS complexes with a consistent PR interval of 0.22 seconds. During your assessment, you notice his resting heart rate has historically been between 45 and 50. Which component of his cardiac conduction system explains his bradycardia? A. SA node with physiological adaptation from athletic conditioning. B. Partial block in the left bundle branch. C. AV node dysfunction caused by second degree block. Or D. Enhanced automaticity of the Purkinje system. Why A?
He's a marathon runner. He's asymptomatic and it's
When I wrote this question up, my first thought was, well, why am I even there? He's not having any complaints. So anyway, but I like this question. Now let me ask you a question. Normal P waves followed by normal QRSs with a consistent PR interval of 0.22 seconds. It is, let's say that it is also regular. Name that rhythm. It's exactly what it would be. Some of your questions will be the criteria and not the EKG. So you'll see, much like with the next slide will be an EKG, but some of these questions I will say, okay, this is what you're seeing on the monitor. Name that rhythm. Very good. Very, very good. What you got there? Sinus rhythm with first degree block. Sinus rhythm with the first degree block. Okay. What's that rhythm? I got an SVT. Anybody else? That is an SVT. Now let's think about this for a second. First of all, what is the big concern with a patient that has an SVT? If that's a 6-second strip, what's the concern about how that patient may present? All right. Why? So okay, decreased cardiac output. Excellent. Dylan. Why? Yes. Not only the ventricles, but the atria as well. So again, because they're beating so fast, it's got to have enough time for that blood to be ejected into the atria and then down into the ventricles. Because it's beating so fast, your preload now becomes narrow. Okay. Remember, when we reduce preload, what do we do to cardiac output? We decrease it. When we decrease afterload, what do we do to cardiac output?
Increase.
We increase it. Okay. Very good. All right, here's objective 3. Trace a drop of blood from the vena cava to the aorta. A patient in congestive heart failure has pulmonary edema, fluid in the lungs, on auscultation when you listen to it. You suspect some type of a dysfunction with the left ventricle. Based on the normal flow of blood, which of the following best describes the structure that receives blood just before it enters the left ventricle? The pulmonary veins, the right atrium, the left atrium, or the aorta? Left atrium. Okay, left atrium. Everybody got that? Okay, good. Name that rhythm. Say it again. Okay. I thought you said tachycardia. I was going to slap your hands. Sinus tachycardia. Now, what causes sinus tachycardia? What are some causes? Say it again. Exercise. What else? Caffeine. What else? Stress or fear. Okay. So again, sometimes your patients can have some symptoms from sinus tachycardia. Our goal is to treat the underlying cause. Okay. So if it's coming about because of exercise, that's a normal response. So when you stop exercise, it should go away. When you're taking in caffeine, when the caffeine dissipates out of the body, heart rate should come down. We deal with the anxiety or the fear or the stress that's causing it, and it should come down. Again, this is usually not a life-threatening rhythm, but it does not necessarily mean that it could not be symptomatic. Hey, pain will always cause your heart rate to go up. Yes, very good. That's another cause. Yep. Okay, anybody else? Name that rhythm. You notice I have a number of sinus bradycardias and normal sinus rhythm with first degree block and a few underlying rhythm with PACs. I wonder what I'm trying to do there. Make sure you give me the full title. Good faith. Very, very good. Excellent. What is your concern about sinus brady? Symptomatic or not. Remember, this could be a completely normal rhythm, or your patient could be having symptoms. If they're having symptoms, why are they having symptoms if it's related to this rhythm? Because of, I can do this all day. Not necessarily to decrease preload. What were you going to say? What? Now you're just guessing at things. What is the most likely cause if this patient's having symptoms, if this is the rhythm? Okay, let me go back. What was the most likely cause when you had SVT? Well, this could come about as a result of sleep, but if they're having symptoms and it's related to this rhythm, it's because the rhythm is too slow. Okay? Remember, we can have rhythms that are too fast, we can have rhythms that are too slow, and then we're going to have rhythms that are just right. Okay? So again, your patient may be okay with this, or they may be having some chest pain, or maybe be diaphragmatic. They could be having the exact same symptoms that you guys correctly gave me when we were talking about SVT. But the cause is not because the rhythm's too fast. It's because it's too slow. Okay? Think about it this way. You're working, you're getting your normal hourly wage, but your hours have been cut now. That's this right here. Okay? During transport of a 68-year-old with massive pulmonary embolism, the monitor shows increasing signs of right ventricular strain. The right ventricle is really working hard. Which of the following pathways is immediately downstream from the right ventricle in a healthy heart? Pulmonary arteries, pulmonary veins, left atrium, or superior vena cava? Pulmonary arteries, okay? Pulmonary arteries lead into what? Into the lungs. And what happens in the lungs? Diffusion. Good.
One.
Why is it secondary type 1? Going, gone. Excellent. Yeah. Going, gone. I like that. PR interval, longer, and then we drop. What is your big concern with these particular patients?
As they're dropping QRS complexes, that's losing a contraction, which is decreasing your cardiac output.
That's one thing. Okay, so with all blocks, let me back up. With all high degree blocks, we have two major concerns. That's one of them. The rate has dropped, which reduces our cardiac output. What's our second concern? On all high degree blocks, secondary type 1 and up, we're always concerned that it will progress to a higher degree block, which leads to electrical malfunction of the heart. Okay, so we're always going to be concerned about that coming into play. All right, this one I think we've already shown. That's supraventricular tachycardia. We've done that one already. All right, one of your objectives on your study guide is what's the 3 layers of the heart. You're treating a trauma patient who has a deep laceration to the thigh with bright red spurting blood. As you apply a tourniquet, your partner asks, what structural feature of arteries causes them to spurt under pressure? Which layer is primarily responsible for this pressure control? The tunica intima, tunica media, tunica externa, or the endocardium? Why the media?
And it's the muscle.
Middle, and that's the muscle. Excellent. Very, very good. That's the part that contracts and it causes the reduction of the lumen of the artery. Let me put it to you this way. This guy's going to be having symptoms. I hear secondary type 2. Anybody else? It is a second degree type 2. Okay, so if we look at here, look at your PR interval. Look at that PR interval. Look at that PR interval. And then we got all these P waves over in here where nothing is happening. Again, this is a higher degree block. What are your 2 concerns? I'm repeating myself not because I'm old and forgetful, but because you got a quiz or you got an exam on Wednesday. What's the 2 concerns you have with a high degree block?
Lowered rate of cardiac output and lowered electrical death.
Electrical death. Very good. Okay. Another objective that you got. Know the impact of the sympathetic and parasympathetic nervous system on the heart. You're treating a 62-year-old male complaining of palpitations and chest pressure. His ECG reveals sinus tach at 126. He's anxious and admits to recent use of an over-the-counter nasal decongestant. Which branch of the nervous system is most likely dominating his cardiac function? Somatic nervous system, parasympathetic nervous system, central nervous system, or sympathetic nervous system? What's the sympathetic nervous system do to us? Fight or flight, which results in what? From a cardiac perspective, what does it cause? Increase in heart rate. What else? What's it do to your blood pressure? Increase in blood pressure as a result of vasoconstriction. All right. Name that slide. A little tricky, but there's enough information there to answer. So I got a second degree type 1 up here on the front row. Anybody different? It is indeed a secondary type 1. And again, ladies and gentlemen, boys and girls, why are we concerned with secondary type 1? Huh? All I heard was
Electrical death and decreased cardiac output. due to-
absolutely. Absolutely. Say it again. What would turn that into SVT? Rate of over 140. Excellent. Excellent. Be very, very careful.
Sinus arrest.
Got a sinus arrest on the front row. Now he's got a sinus block.
Sinus arrest.
Got another arrest. What do y'all think? You're all. So it is indeed sinus block. Now, again, this is one of those situations where if you're not sure, take your piece of paper that you can have and measure your R to R's and your R to R's, and you will find that your R to R will fall probably right about on that line right there, and then it picks right back up. Okay. What are some causes? What is the primary cause that we're concerned about with sinus block or sinus arrest? There's multiple, but there's one that we're really concerned about.
It keeps happening.
If it was with caffeine, the heart rate would be up.
If it keeps happening.
Oh, definitely. But what I'm talking about is what is the
main concern.
What's the main concern as far as? Let me try to rephrase this. Of the cause of it. What is something we can address as paramedics, but what is the number one cause that we got to be thinking about? As far as the cause of this and sinus block or sinus arrest. It starts with H, and the second letter is hypoxia. So hypoxia is a concern that we would have for this. Okay, there's something that's going on. It could be medicine that the patient's taking it, and we can't do anything about it. It could be an electrical abnormality that could potentially be congenital, and there's nothing we can do about that. Hypoxia, we can do something about. Okay, all right. Next one. So I got a second degree type 2 on the front row. Anybody else? Okay. Isn't that nice? Skylar thinks you're right. It is secondary type 2. Okay. Secondary type 2. All right. Now, brings us to the end of our review. Let's talk a little bit about the exam. Here's your options for extra credit. Number one, remember, AFib and A-flutter will be on this as well. I didn't have any of those on there. But if you got A-flutter and you've got either variable conduction, or you can tell me it's a 2-to-1 or 3-to-1 or whatever, and you tell me that right, bonus questions, okay? If this class, because you guys are pretty high performing, if this class has a class average of 84%, I will give everybody a 10% bonus on your exam as long as your individual score is 80% or higher. Okay? So you have a team effort. So remember, everybody's depending on you to do your best, but you also got an individual effort that will help you to earn some points. Okay? I need everybody to be here because we're getting closer to the end of the semester, and so it's going to be harder to reschedule and bring you in for an exam. Again, if you're sick, I understand that, okay? But again, if you miss this exam, you got 1 week in which to make it up in, okay? Any questions or anything that you want to review that we have not reviewed